Good morning, everybody. It's a privilege to be the acting chair. Nobody's quite sure how long this temporary promotion is going to last for, but those who are experts in government think it could be months. Anyway, I'm delighted to be able to do this. Now, of course, I will never be able to remotely be as effective as David, but and as I've mentioned to colleagues, I think it's a real accolade to the CQC that our chairman has been appointed to the government. Although Robert makes the important point that it also perhaps puts a responsibility on us to be even more clearly independent and an independent voice than we were before, even though we were completely independent before. We've got apologies today from Paul Corrigan, Paul Rue and Camilla, which is slightly unfortunate because there are important items on the agenda. And Sandy has mentioned that Anna is going to be late, but she is going to be able, she is coming to the meeting. If we just go through the minutes of the last meeting and the action log, I don't know if colleagues have any comments on those or whether we can take those as read and go straight to David. Any comments? The only item on the action log, which I think we'll return to, is David's letter to Lewis about whether there has been a significant trend downwards in enforcement actions, and we'll come on to that. And Jennifer's got has been working on that too during the session on the quarterly performance report, although it's also an annual performance report. So, David, would you like to?
Thank you, Michael. Good morning, everybody. I'll begin this report by echoing the comments that you've just made by way of introduction, Michael, in relation to David's, I think it's elevation to government, and I just wanted to acknowledge as Chief Executive just how valuable and how appreciative I've been of David's contribution to CQC over this past 2-year period. The relationship between the Chief Exec and Chair is an important and critical one to any organisation, and I have to say it's been a pleasure to work with him as closely as I've been able to do. I agree with you, it's a real fillip for him to be promoted to government, and I think Robert's point about independence is absolutely critical. But I think I'd like to add my congratulations to David on his promotion. In paragraph 2, what we've gone on to do is just set out, as this was drafted and circulated to you on Friday afternoon, the list of appointments to the ministerial positions in the Department of Health, and also reflected the Secretary of State's initial comments on how he regards his priorities, and they're in italics in this report, about out-of-hospital care, general practice, and social care, community healthcare-based services as well. We've also taken the opportunity just to set out some of the content of that which was in our business plan about how we will develop our work this year. I think there is a symmetry between the two. Yesterday, I went in to meet Ben Gummer, who is the Minister for Care Quality, not the Minister for the Care Quality Commission, but for care quality more generally. And the issues that we discussed were his experience of us in relation to Ipswich Hospital, which was positive, his confidence in the reports that had been made in relation to adult social care and care homes in his constituency, which was positive. He reflected on our role in commenting on efficiency the importance of patient experience in arriving at judgments around the quality of services. He will be the minister that will make a decision about cost recovery and fees, and we anticipated that. He is interested in, more generally, the issues around hospitals where there's a need for improvement. And we also discussed our new role in relation to market oversight, and he regards that as being important and significant. So in a sense, that conversation gives some reflection of his priorities and how colleagues in the executive team will join in those discussions. I think Mike had also had some discussions earlier in the week with him in the wings of another meeting that took place. Is it worth just pausing there, Michael, in relation to that bit of the report? The rest is much more about our performance and where we go, but I'm happy if any board members wish to make any comment on either of those issues.
Do you colleagues have any?
Okay. This report is less on our performance because the performance report, which is the next item on the agenda, is a full report. It's a year-end report. It captures all 4 quarters. So I'm not minded to dwell on paragraphs 3, 4 and 5, Michael, at all. We've given the up-to-date position at the 8th of May in relation to recruitment, 385 offers made to inspectors and 71 to managers, and reported on the uptake of training. We've got later in our agenda Dr. Bill Kirkup, who's going to come and share his findings in relation to the investigation that he conducted in relation to Morecambe, and then he'll give a seminar to staff who can join digitally, but that will be recorded and will go on the education development system in there for all those colleagues who want to view that at a later date. So an example, I think, of how the Academy is developing and using digital technology to help in relation to this. In adult social care, Andrea may want to comment. We note the performance in terms of inspections completed and ratings given. We flag the progress that has been made on market oversight with the appointment of Stuart Dean and Peter Holton. Very good appointments and really good progress being made there. I think board colleagues already know that Sue Howard has now been appointed to the Deputy Chief Inspector post in the Central Region, and a very well-deserved promotion for Sue. And I have to say, I've been impressed by the way that she's taken the interim role and then managed to secure that senior role. Worth emphasising the importance of the work that we're doing on registration. We've had a very clear programme structure to the review of new methodologies and the way that we've inspected hospitals, adult social care, primary medical services, etc. And we're bringing a similar approach and discipline to the way that we're actually looking at reviewing the way that we register services. And hugely important piece of work. And we've set out the terms. Andrea will oversee the development of this work and bring it to a conclusion during the course of this year. There's work taking place on report writing. We touch on this later in the performance report about the importance of both the quality of reports and the timeliness of reports. In relation to primary medical services, you've got an update in relation to ratings as at the 8th of May. Again, Ursula Gallagher appointed as Deputy Chief Inspector. I think we've now got a full complement of Deputy Chief Inspectors across the organisation. Ursula joins us from as a nurse, but joins us from having worked in clinical commissioning groups, and I think is again a first-rate appointment to the organisation. On hospitals, an update on that which was rated during PERDA in the run-up to the election. We carried on as business as usual, undertaking inspections and publishing reports, and we bring those together for the first time at the bottom of page 6. Flagging on 9 the importance of thematic work. This was signalled in our business plan last year and this year. It's an issue that the board has taken interest in, and what this is signalling is the beginning of the work that we're undertaking on a thematic report on integrated care for older people. Hugely important given the prominence that has been given during the election to integration, and allows us to send a signal about how we are developing our methodologies, so we're looking thematically, not just at the institutions, and this gives us the opportunity to look at the impact of health and care services on older people with multiple and complex conditions, rather than just looking at the individual care home or the hospital service. So a hugely important development, and we'll aim to complete that and publish that in April next year. It is consistent, I think, with some of the emergent priorities of the new government around care for older people, and just to emphasise that this is one of those areas where we do need the agreement of the Secretary of State to actually take this forward, so that process has begun. For continuity, David was prior was keen that we held a symposium looking at the robustness and resilience of the adult social care market, and the work for that is underway, the planning for that is underway, and we anticipate that that symposium will take place in July of this year, where we'd hope to bring together some of the leading providers and analysts in adult social care to look at the robustness and resilience of the domiciliary care market. The Guardian covered this, touched on this yesterday in relation to domiciliary care, and the fact that there's a number of large providers that are selling domiciliary care businesses on the basis that they are not viable. Banks aren't tending to lend to domiciliary care organisations. So that, I think, suggests some important questions about resilience in the future for what is a critical service. So the purpose of the symposium will be to discuss the different perspectives that exist within the sector, the commercial, the lending, the provider perspectives, with a view to us being clear about what the implications are for us in the way that we regulate for quality and safety during a period of extended austerity in that setting. An important appointment, just to conclude, Michael, is of Annette Godwin, who joins us as the Head of Procurement. This is an area that Eileen's been working to strengthen our capability, and Annette has been appointed to do just that. I think she'll join us later this afternoon, where we'll consider in the private session a procurement. It'll be in private session because of the commercial sensitivity until it's agreed. So board members will get an opportunity to meet Annette later this afternoon. So if I leave it there, thanks, Michael.
Thank you, David. Does the board have any questions or comments for David? Kay.
Yep, it's a question actually on the thematic review of integrated care for older people. It's about the scope. I mean, are we going to include mental health, and are we going to include equalities or inequalities within that scope?
Yes to mental health. It is older people. We did have this debate about over 75s and not, and the reason we drifted away from not having over 75s is it wouldn't capture early onset dementia. So there's a sense of where we need to look at those services. So early onset dementia, as you know, Kay, you could have people in the 50s, well, indeed even earlier, I think in some cases, but we didn't want to get hemmed into a specific age range. The issue is multiple comorbidities, and that will tend to mean that these are much older people. It begins with fragility more than the routine is dementia. We did that work last year on dementia, looking at the interface between care homes and acute hospitals. So we don't want to repeat some of that, but we're going for that. So can you do the other bit?
Yes, certainly on excuse me, equalities and making sure we understand what the variation is. I don't think the plan is to specifically step through the inequalities in each of the 9 protected characteristics, but we will certainly be looking to expose variation, yeah.
Jennifer.
Thanks. Also on the thematic work, it's a very, very good area. I just wondered if part of that work is going to involve looking at the metrics that people are using to assess whether integration is actually happening. I mention that because it's a big deal with the Vanguard sites at the moment and other integrated care pilots to try to... So as part of that work, if there's some sort of collection of information as to what metrics people are using and what they find most helpful, I think that would be really useful.
Yes.
Thank you. Sorry, I just want to add one other question. It's not really our responsibility, my question relates to, which is about market oversight of ASC is our responsibility. But given all the discussion about the Care UK selling the mental health and the learning disability on, in market oversight of healthcare is not our responsibility particularly, but I'm just wondering whether we have things to say to those for whom who do have that responsibility, given our market oversight and social care work.
I mean, I think this is a really great question, if I may say. The way I've been viewing the work that Andrea's been leading, and with somebody of Stuart Dean's background and capability, I think what it does is we have in that developing team the capability to do the specific job that we've been asked to do in relation to adult social care. But in addition, I think what we get with those colleagues joining us and their backgrounds is we enhance our ability to analyse the health and care market. And the specific example you quote, Jennifer, makes a point brilliantly that there are some providers who are providing health and care, and the economic and financial environment that they operate in is the same. And so I think our ability to understand what's happening in the market, understand where equity finance is flowing, how equity finance are making decisions, what they're investing in, what they're choosing not to invest in, is absolutely critical. My understanding of the UK decision around there are other businesses is it's driven by different issues than the domiciliary care business decisions. But I think understanding that more fully and the kind of refinement behind it, I think we do need that capability. So we have a specific statutory role that we're given, but I think the skill and the capability will enhance our ability to look more broadly as well.
And if I might just add, we've also been working with Monitor in the development of the market oversight scheme from our point of view, both to learn from what they're doing, but also to establish really good relationships between the various teams, so that in terms of looking at the overall picture of the health and social care economy, there is a shared understanding that they can benefit from. I mean, clearly, we would only be doing that with information which we can put into the public domain in an appropriate way, because we will have access to confidential information which we are very clear will remain confidential within CQC, and we're managing that very tightly. But taking that to one side, the kind of general point I think is really important in terms of the conversations that we can have with both Monitor but also the Department of Health. Indeed.
Lewis.
Thanks. Some of what needs to be talked about, I suppose, in relation to the individual inspectorates will come up under the next item, which is about the all the information and the report. But since it's in this bit, can I just mention just highlight one of the figures that's here under adult social care. So you have to sort of stop and remind yourself that these figures are probably right, which is that since October we've had 4,800 social care inspections. 4,800. That is an unbelievable number. I don't mean that literally unbelievable. I mean that's a rather striking number. I mean, the first thing I suppose is to acknowledge what an incredible effort that is. That is a fantastic human effort. It breaks down to, I'm not sure when it's up to, but it's from October, so that's probably about 700 social care inspections starting every month. So by given the fact that about 20 working days per month, that's about 35 starting every day, which is an incredible thing. But once you get beyond the admiration, I suppose it's just a question of...
I knew there'd be a but.
The obvious questions about sustainability of that effort, which is huge. There's a question about the how I suppose how accurate it can be, how much inspections that are happening, there's so many inspections happening, can get under the skin of actual social care performance. I'm not suggesting they don't, I'm just saying that must be a challenge. And how that then breaks down to different sorts of services, because some of the services, we've got quite a range of social care services and settings here, which presumably are different, and the distribution of ratings may be different across them. Even allowing for that, 1 in 12 is inadequate, which is is quite a lot of people getting inadequate care, social care. So I just it'd be useful to have your reflections on the issue of sustainability, the breadth of settings, and also this figure of 1 in 12, which is troubling, I think.
Well, thank you very much, Lewis, and thank you for the appreciation for the staff in terms of the work that they've done, because I think that they'd really appreciate that acknowledgement. I spent yesterday with all of the Northern region team, and one of the kind of messages that was coming out from that conversation with staff was, they have been under an awful lot of pressure, and they've been working very hard to deliver inspections and the new methodology and to respond to risk. But actually, in terms of thinking about sustainability, one of the things that I think that we can take comfort from is the dedication and commitment of our staff to actually do this, and that was something that came out in the staff survey last year as a really positive purpose that people see that they're doing. So that's the first thing to say. The second is that we have been in common with both hospitals and primary medical services, recruiting to a fuller establishment of inspectors. So we've not had all of the inspectors, even in that period where we've been doing those inspections, we've not had our full establishment in post. And even where we've had some staff actually on the books, there's been other reasons why they've not been able to do inspections. But as a consequence of the incredible efforts, both from the recruitment team in human resources, but also managers within the inspection directorates, we're really motoring now with recruiting and getting people into post. Really important issue now about making sure that they're getting decent inductions, because actually this week we've got a specific role induction starting for inspectors, and we've got 60 people doing that, which is a tremendous number of people. So there is something about, yes, it's great to have the new people and we definitely want them, but there's also kind of making sure that we're training them up. So I think the sustainability will also come through with increased numbers. And the third aspect of sustainability is looking at how we can make the process of inspection, rating and reporting more effective and efficient. And that's both in terms of looking at continuous improvement of the way that we do it, and the various, there's little things all the way along the path that we can do that can make things better. But there's also some of the bigger items around how we use our information database and how we can support our staff from a systems and processes point of view to do things more quickly. And it's certainly been something that we've built into the expected trajectory in terms of inspections over this coming year, is actually an increase in productivity as a consequence of some of those things. So we've been looking at that and been talking to Michael about the presentation that we will do from adult social care to the RGC in June, and we'll kind of put a lot more flesh on those bones for you in that. So that's sustainability. The breadth of services, you're absolutely right. We break it down into 3 different handbooks for adult social care, community services, residential and hospices, but even behind that there's a whole set of complexities and differences around mental health services, learning disabilities, physical disabilities, services for older people, and the difference between residential care and nursing care. So one of the things that as we get our staff fully up to speed, we'll be looking at making sure that we're the portfolios of locations that individual inspectors have are attuned to their areas of expertise as well. But we're doing a lot of work with the Academy on making sure that we can be clear what good looks like in each of those different areas, so that there's actually training and support for our staff so that they can do that. Coming on to your final point, which is the numbers of inadequates, I think that we need to set this in the context which is that we are responding to risk as well. So this isn't just a kind of schedule of, you know, at random going out to places. We are making sure that if risks are identified around individual locations, we are going out and doing full comprehensive rating inspections as a consequence of that. So there will be a skew towards more of the inadequate and requiring improvement services than the good and outstanding in the first few months of doing the inspections. So I'm not a betting person, but I'm sure we won't end up with 10%, as it's kind of close to being inadequate. But even so, the numbers that we are seeing are demonstrating, I think, a couple of things. One, we really are getting under the skin of services. And we really are finding out what is happening, and we are getting challenge from some providers who have been compliant in the past, and we're going back, we're doing a much better job, we're doing a much more thorough job, and we are discovering and identifying things that we weren't seeing before. So actually, I think that one of the reasons why we're seeing those inadequacies is because we're doing a better job, which is important. The second thing to say is some of those inadequate services are truly, truly awful, and we are taking enforcement action, and some of them will not continue. Some of them will have the capacity to improve, and we need to encourage that and move them along, but we will be keeping a very close eye on those services, and in our methodology we will absolutely be going back within 6 months to check that that's the case. And as of the 1st of April, services that have been inspected and rated as inadequate will be in special measures, which for adult social care, as you recall from the last time we had this discussion, is really about being very, very clear about the timescale that people have to improve, and making sure that if they don't, we're taking the action, which will mean that they'll be taken out of the market if that's the right and proper thing to do.
Any other questions before we go on to the performance report?
Which I was going to ask this when we dealt with the performance report, but we seem to be talking on the subject. But as I understand it, that if I read the performance report correctly, we've inspected some 10% of those establishments we need to inspect, and so which prompted in my mind the question: well, if that rate even accelerated, but is continued, how long before we get round the parish? And if you say, as you have done, that the figure of inadequates and requires improvement may be a bit heavily weighted at the moment, but that's, 41%, even if you halve that, then there's a lot out there that we haven't yet come across, because not everywhere has whistleblowers, not everywhere has that sort of the leakage that comes to us. And I just wonder what we are doing to ensure that we have a priority about rooting out and exposing that. And frankly, I suspect it's a question across the inspectorate, it's not just for you. That's one aspect. The other thing is about effectiveness. Part of the effectiveness, I'm sure we all accept, is in the information we give to the public about what we find. Which is really important, and that, of course, is through the reports, and the report writing is mentioned here in David's report. I just wonder whether, having read a few reports recently, we sometimes resort to formulae underlying which is a lot of stuff which, if we explained it more, would have real impact with the public. That's the first point. So what makes an impact with the public is the effect of a story which shows how the inadequacy that's been identified impact or will impact on the human beings, either the residents or the patients or indeed the staff in an institution, and which is one side of it. And the other is although we do give examples of evidence, and I can fully accept that, whether we actually make the reports a sufficient description of the evidence that we have found, so that it's not so easy for the owner or the provider, wherever it is, to say, oh, well, this is just a bureaucratic reaction to something and it doesn't really have any effect on people. Because after all, that's what we're there to do. And I hear that, and I'm sure we all do, and I'm pretty certain it's not the truth in terms of these reports. So those are the two things. One is how are we going to get around the parish to root out and expose the bad soon enough before we hit more disasters. And the other is how we are explaining ourselves through our reports, which are a magnificent means. And don't get me wrong, they are fantastic pieces of work, but it's whether we can clarify the expressions we use of what we find to make even more impact.
I think those are excellent questions. But as Robert said, maybe we should. I think each of those is actually addressed by one of the pages in the performance report. So I think we should use the performance report to surface the answers to those important questions. Just on Robert's second point, I don't know how many colleagues are on the CQC's sort of press cutting circulation that comes out every day. I'm on it. I mean, I can't pretend. I mean, every day there's, I don't know, 100+ stories. But it is interesting how the local press, when a home is inspected, often covers the CQC reports. I don't know if we've actually checked how many of our reports actually are covered by the press, but I think it'd be a very interesting exercise to do, because I think that would help with Robert's second point, to get an understanding of, are we either writing them in such a way, or are the press releases written in such a way that they do get coverage locally. So perhaps we can, Paul, you can ask a colleague to check that. And
we certainly do. We know that. We can provide that analysis. We have clear rules on what we do and don't press release, partly because it would deluge the media if we press released everything, but we do want to make sure there's particular concerns or outstandings that we're either individually for a provider in the press release out, or if you remember earlier in the year we did the examples of excellence, so the national and the local media could also see all the excellent care that's out there.
Good. Well, Paul, I think you're... Oh, David is going to take us through the performance report. I think the question about enforcement we can discuss when we get to, and this is one of the problems with the performance report, which I think we're going to attempt to slim down a bit, but when we get to slide 20, it does cover enforcement, and then we can hear Lewis and Jennifer's views on those. So, David.
Yeah, Michael, thank you. I think this is me because of the oversight that this report provides of the whole organisation, but our colleagues will join in the explanations of what we've been doing. So I'm going to go through this and invite you to look at both the slide pack as well as the covering report as we go through the detail of this. By all means, if I don't cover something, come back. The detail of this is here. If you remember previously, we've had a conversation about there's too much detail here and not enough detail. So just spanning that dilemma. Paul Rue asked that we bring back on those areas for development I'm going to touch on, and that colleagues will join in answering any questions, to subsequent board meetings, a more detailed analysis in this report, and I just want to flag that we will bring back reports which go into further detail. And just to pick up the point that Michael's just alluded to, rather than take information out, we think there's duplicate information in the slide pack where there's a table, a pictorial representation, a graph or a histogram or something, and a word description of it. So in a sense, we do 3 different ways of actually making the same point. So I think the challenge is, can we make the point in one way and actually have confidence in your ability to fill up those issues, whichever way we actually go into it. So with those caveats, paragraph 2 really flags up the volume of activity which has been undertaken, and just to echo Lewis' appreciation for the acknowledgement to the work that people have undertaken in that respect, and that's set out in the PowerPoint presentation, the slide pack on pages 26 and 27. Robert, to your point, that is just under 10% of all organisations that we've rated under our new inspection regime. Our business plan said we'd complete that for March 16 for Mike in acute hospitals, and then at the end of September 16 for primary medical services and adult social care. So on the basis we recruit at the rate we have been recruiting, I think that is when we'll have completed the first round of inspections. On the point of enforcement, to the end of the year, during 14-15, we undertook 1,179 enforcements, which is a decrease compared to the previous year. But we've completed fewer inspections during this year than we did in the previous year. So when we've actually expressed that as a rate, then you'll see that we've got an increase in the rate of enforcement activity which is taking place, an increase from 3.8% to 6.6%. And that's set out on page 29. Lewis, you raised this issue at our last meeting on the decrease which takes place, which was apparent in the figures between the period November to February. What this report has done is show the figures after we've rerun that data with the increased activity being included on our database, and you can see from the slide and the figures that there's been an increase in enforcement activity. You also asked, I think, Lewis, if I remember correctly, that we represented this not as a global sum between all for the organisation, but broke it down by directorate, adult social care, primary medical services, and hospitals, which we've done. Moving on, the complaints are showing a decrease based on last year's performance. It's not a huge decrease, but nevertheless it is, and that's flagged at page 21. I think there's been some impressive work at the National Customer Service Centre where they've managed a volume, an increase in the volume of business that they are receiving, and have managed that increase in volume within their resources and managed to meet their performance targets as they've gone through. Previously flagged the issue around registrations, and in paragraph 2.7 and page 25 in the slide pack, you can see that we've had a significant volume of registration activity. A lot of this is changes to partnerships, changes to registered managers, etc. But there's also a significant number of new registrations which are apparent in there. Some good news. The last Gateway review concluded that the transition programme, which has now ended, was given the overall status of amber green, which is a good rating. Unusual in my view that gateways give amber green ratings. very unusual that they give anything higher than an amber green, to be honest. And I think that's a tribute to Hilary Reynolds, who's now gone on to other jobs, but also Mark Edmonds in Paul's directorate, who've overseen the programme management. And I think certainly gives me some confidence about our ability to manage at a programmatic level the changes that we've been taking forward, and the programme approach continues through this year as well. But the meat of the report, Michael, and perhaps the discussion focuses on these 4 areas for specific development, which we'll take in turn. The first one is flagged on slide 20, which is the number of locations and providers not meeting one or more of the standards for more than 12 months. This is an issue which we need to take seriously and address, and Chief Inspector colleagues are indeed doing that. I think the some important points to pull out, but by no means all important points, is that the issue which has given cause for concern may change during that year. So there may be initial concerns that are arisen in, say, care home medicines management. That might be addressed. The re-inspection then identifies another issue, might be appropriate staffing levels. So the cause for concern changes, but nevertheless, that provided that location will have been causing concern for more than 12 months. So work is underway by all directorates to understand why those concerns continue and what action is required to take them forward. Now that special measures is in place from April of this year for all services, adult social care, primary medical services and hospitals, then we've discussed before that the impact of special measures is effectively to time out the number of chances that people will get to put right the concerns that are there and identified through our inspections. I don't intend to dwell on safeguarding. We've gone through this on 3 or 4 previous meetings. There is a policy review which is being led by Sally Warren in her capacity as chair of the Safeguarding Committee within CQC. And colleagues have got specific action plans in place to ensure that all the alerts, i.e. when we are the first organisation contacted because of safeguarding concerns, they are dealt with in a timely and an appropriate manner, both at the National Customer Service Centre and then when they're referred through to inspectors at that level. And we are presenting the data in this report in the new format that we agreed, I think it was in February. And we said we'd review that in July of this year and then confirm whether that's the appropriate data to be collecting, and that allows us to dig under our own performance and whether we're making the appropriate improvements in our activity. On publication of reports, I think there's 2 issues here. I think some of the earlier questions were about the content of reports and the quality of the reports, and then the second issue is about the timeliness of the reports. The majority of this performance report is about the timeliness of reports, and this is an issue that we are attending to for 2 reasons, I think. Firstly, the significance of this is that where members of the public use our reports to make choices about the selection of services, particularly adult social care, but not exclusively adult social care. I would argue the same might be true in things like maternity services, for instance. Then it is important that any report that we are going to make is made in a timely way. Otherwise, the risk is that people will select a service about which we've got concerns, but we've not published that. And I think I've certainly received a number of complaints directly into my inbox of people who are angry and frustrated that they've made a choice about a service when we've had concerns about it, but we've not yet published the report. So the timeliness of this, I think, is less about the bureaucracy of the organisation and more about ensuring that people are able to use our reports to make informed choices. I think also where organisations need to make improvements, I think this is behind your earlier question, Robert, it's important that those reports go out quickly and are in the public domain, and then there's a transparency about not only what we've found, but it gives providers the opportunity to say what they're doing to actually affect those improvements. And then the fourth area that this report draws attention to, Michael, is about data quality and completing CRM. A lot of the issues, Lewis, your point earlier about enforcement activity is really about the flow from the completion of the activity to that being loaded on our database, and then that data then informing our management of the organisation or the publication of data. There are all kinds of challenges with that, and later in this report, today, there is a report that invites the board to consider a decision in relation to some procurement which will have the impact of improving CRM, of simplifying CRM, so it can go back to being used for what it was designed for, rather than the adaptations which have been introduced, which is actually putting stress on that system, which then knocks back into the delays in terms of loading data and being able to extract that data. Don't want to blame the system. There's behavioural issues here about when people complete a task, they need to complete it, and that completion means loading it on the system. I think we'd have a view when we go out to inspect, if you've not recorded it, it's not been done. And I think the same metric needs to be applied to us. We can't apply it to others and ignore it for ourselves. So I think this isn't just about systems, this is about our behaviours, and we need to address that through that. And I think what we're trying to do in this report is flag that. This, because it's a year end, you've got unaudited, the audit hasn't been completed, financial figures, those year end figures are being brought to a conclusion, but these are month 12 rather than month 13 figures for finance, and you'll see we have an underspend of 18 million, which is made up of 13.3 on pay, non-pay on 14, and depreciation of just under £1 million. With the capital allocation being underspent. The risk register is appended. We invite you to comment on confirming data for the annual report, and we also confirm that we'll continue to report on our performance monthly to the board with a fuller, decluttered, if I can use that phrase, performance report coming on a quarterly basis. So that's a report, Michael, and there's lots in there for us to discuss.
Thanks, David. Perhaps we could actually go first to slide 29, because this is basically the slide that lays out the change in enforcement actions. There's a little table on the right. So I thought this would be the opportunity for Lewis and Jennifer to let the board hear about their view on enforcement actions. Perhaps, Lewis, you've had the letter from David. You can see a trend here. I don't know what your latest thinking is.
After the build-up, I hope my response is going to be sort of match-ups. Well, broadly, I was happy with the letter. I was glad that to get it, and it took what I think we all think is an important issue and explored it. So just to remind you, David's letter said. So I was asking about the reduction in enforcement activity over the most recent months, and David's letter said that there were two reasons behind that. One was the reduced number of inspections, and the second was, I suppose, essentially delays in getting the results of inspection up onto the system. And there were a number of components to that. David's just outlined what some of those components are. And that seemed fine to me. I was slightly surprised there was a reduction in the number of inspections, I suppose. I was surprised. And I understood if I understood what you meant by that, it's that is the new model. That that helps. Because obviously we are doing a lot of inspections, as we've just been talking about, so that it doesn't seem like there's too much of a reduction. And it sounds like that those figures are fully proven by the rise in the percentage of enforcement actions. So that seems fine in answer to the specific question. The reason I asked that question, though, was that my concern, I don't suppose it's just me, that we are able to demonstrate what are the benefits of having CQC call. And so it's the broader issue of what is the benefit of what we do. And at a time when, we're going to be discussing how much money we receive from the government and from trusts, from provider organisations, it's absolutely vital that we're also able to say what we do with that money, what we achieve with it, what we achieve for the public and for patients. £200 million is enough to pay for 2 mental health trusts, so it's it's a substantial amount of money. So it's more that's my broader point about how we demonstrate the benefit, and enforcement is one part of that, but there is the broader issue of how we assess the impact. I think it goes to this point about what happens when people are non-compliant for a long period of time. What is not just what are the numbers, but what is the flow diagram? What happens to them next? How do they get out? How do they move on to a higher level of enforcement? And so that at some point, I just feel we've got to be able to say to the public, as a result of CQC, we've been able to do the following things. And number one on the list of what we ought to be able to do is to root out unacceptable care. Because that's where we've got to start. There are a lot of other things we might do which are about improvement and all of that, but in the end, rooting out unacceptable and dangerous care is as I see it, our number one task, and we've got to be able to make a convincing case for that. And so these enforcement figures are, if you like, the sort of tip of how we do that. Actually, they're not really the tip; they're an important part of how we do that. So that, for me, that is the broader question: how do we demonstrate benefit?
And Jennifer, I think this was part of the work that you were.
I mean, it's Paul is sitting to my left, who's the expert on this, but just to say that a lot of work is being done on the evaluation, not just on the benefits of CQC's work, but also the costs. It's a very comprehensive piece of work. It's a very big piece of work, actually, and it's the most complex I've seen and comprehensive that I've seen. And that includes the time that I was on the Healthcare Commission's board when we were also evaluating our impact. So I think it's a really good, ambitious piece of work. I think we really ought to be all over it as a board, and I think that we've got some time at the July away day to do so, and really we should, I would vote for having quite a chunk of time on it at this point of our existence, not least actually with some of the financial figures that we've got in our end-of-year report.
Paul.
Thanks, Jennifer. That would work very well for us. We'd be more than happy to do that. The reason for the complexity and the time we've spent on it is because of the impact and our need to really understand what our impact is. So I think it was a reasonable criticism of CQC in the past that it judged its impact by how quickly it ticked through inspections, which is a complete activity measure. We know we need to do the inspections, but we've tried to move much more towards a quality point of view. And I think, as you say, Louis, one of the outputs, an important output of CQC is the enforcement action we take in pursuit of protecting people and correcting poor practice. But it's still not impact, which is the care getting better. And there is, I think, an analogy with the health system, just to play this through for a second, that it's hugely important that a hospital does carry on with its emergency admissions, but the true measure of a quality of a health service is its ability to keep people healthy, in which case we would hope that emergency admissions would eventually go down, or at least wouldn't rise inexorably. And I think we are playing the same sorts of difficult discussions out that the health service at large is playing out, that yes, it's important that we demonstrate the enforcement that we are doing, But it doesn't mean that just because we do more enforcement, that is inherently a good thing for the system, because it means there's more and more bad practice that we're exposing. So I think we do need to expose the work to the board, but it's also important that we think through right the way back what the full impact we want to have in pursuit of our purpose of encouraging improvement, and how all the way through from the pounds that are invested in us to the staff, to the activities, to the sort of intermediate outputs and the final outcomes, that we play that whole thing through and can understand what benefits that we're delivering for people who use services. So to finish off on the point that Jennifer started with, we would like to expose that work to you.
I think it is a very good idea to have a large proportion of the away day focusing on this, because I think, as Paul is saying, you know, and I'm not sure a chairman is allowed to say this, but unless the system, you know, whether it's health or social care, improves, you have to wonder whether we're doing things in the right way. So,
can I just add to that? Clearly, the factors that influence quality of care are many. So only a very tiny amount in our control. So we're not responsible for overall quality. And, I mean, it's notoriously difficult, therefore, to assess what our longer-term impact on outcomes is. Therefore, process is probably the closest that we can get. So that's point number one. But point number two, nobody really elsewhere in the system is assessing their individual contribution to the quality of care. And that goes for the other ALBs and also other aspects such as the impact or not of competition. Nobody is really fully assessing those things in the round. So we are going, from what I've seen, we have the most sophisticated approach, but also to say that it's a responsibility of others in the system to do the same, lest we forget and think that it's all on our shoulders, which it certainly is not.
any other, Robert?
Just to say, I was going to make a point which is Paul has done much more eloquently than I. In the enforcement is as much a process as inspection, and the importance of it is to patients and service users is what benefit do they get out of it. Now, of course, some forms of enforcement in the short term may have at least the effect of inconvenience on some residents, say, of a care home who get shifted off somewhere else. And in relation to places that are closed, there is a shortage of places for people to go to. So we have to accept, do we not, that enforcement is not always an immediate beneficial thing. But we do need, and I'm glad to hear we will be doing it, we need to seek ways of working out what the impact on people, patients, service users, of enforcement measures are, both in the short and the long term. And sometimes it may be the short term needs to be a little more negative than the longer term. But underlying most enforcement ought to be, and no doubt is, the fact that appalling things are being found. Immediate steps have to be taken to protect people from harm, for example, and that is what happened. But and to say, if I may say, while we need these figures about enforcement, I personally would be somewhat concerned if they became an accepted proxy for whether as a measure of the benefit to people, because, you know, take a simple example, fixed penalty notices shoved on my car provide some money to some local authority or probably a traffic warden, but in my observation, they don't seem to have the slightest difference to traffic jams in London. So it's so we do need to be a little bit careful on how patting ourselves on the back because we're doing more enforcement.
Perhaps Lewis and then Kay.
Well, I'm not sure I completely agree with you about that, Rob. But anyway, I think I'm pleased to hear we're going to discuss the complexity of it. I mean, I think it is very complex, and I absolutely agree that we're not responsible for direct safety of individual interactions between patient and staff. But we mustn't get bogged down in the complexity. It will be complex, but if the complex analysis results in a rather a sort of provisional finding, which is that we may be contributing, and we're still not sure whether this is a improvement or whether people are not just not reporting what we are looking for. And if we get bogged down in that kind of slightly uncertain outcome, then we won't have demonstrated anything. That's the risk. So we will acknowledge the complexity and have no message for the public. And we just absolutely why I think the enforcement matters is that in the end, if you want a relative to go into a care home, the thing you want to know is that the bad care homes have gone. Because everything else is about how good they are, but you really want to know the bad ones have gone. And so the enforcement actions and what follow them up. After all, we've taken 1,300 enforcement actions in the last year, during the last calendar year. Has that been of benefit? I think it's a very important question. And unlike the complexity of understanding improvement, it has an obvious validity to the public. We've shut down the bad places, and we've got to be able to give that message. The message can't be, this is really complicated and we're one of only several players in the field. That's not a good message for the public who are paying for us.
Kay, just before we come to you, perhaps, Paul, you wanted to...
That would be a terrible message for the public, wouldn't it? It was really complicated and we can't say anything. So we acknowledge the complexity only so that we can do the best job in understanding the impact. So we will publish at least an annual report on the impact. My full expectation is that the first time we do this, we will be able to make some statements, but nothing like a comprehensive assessment of our impact. And that will be because there are particular sources of data that we need to get hold of, or we may need to do different surveys, a whole different set of things that we need to collect we simply didn't know before we understood how you assess impact, but it will get better over time. And what we're trying to do is bring some academic rigour to that so that we do cut through it, but we need to acknowledge the complexity. The only other point I make on the enforcement is that as you say, there are well over 1,000 actions. The vast majority of those are not about the act of closing or cancelling a registration. The vast majority are about a warning notice, which is, I think, important for Robert's point about we need to be extremely sensitive to the inconvenience or worse that we cause residents or other people using services. At the moment, the vast majority of what we do doesn't inconvenience them directly. It is a specific action on the provider that allows them to continue. It makes it clear that they have to improve their performance.
Kay.
Okay. So notwithstanding what Lewis has said, there's always this sort of pressure to demonstrate impact, what action we've taken, what has changed. And I do think that's an important element. But equally, we are also, as a regulator, we're doing the shining the light on. We're, uncovering poor practice or good practice, and we're reporting on it. And these are in individual inspection reports, and sometimes in the, the thematic reviews or the state of care report. And it is quite hard to know what impact that has, but it's contributing to a wider body of knowledge. It's contributing to the sort of culture of openness and transparency. And I think those are kind of important things that we shouldn't lose sight of, even if it might be quite difficult to demonstrate what impact those particular elements have. And again, just thinking of the evaluation, I don't know if this is what the evaluation is doing, but I wondered if a sort of case study approach might be helpful, looking from, if you like, the start to the finish, not just CQC, but how we decided to inspect, what we found, how we reported it, what happened, who did what, and how. So we actually have some quite in-depth case studies that also looks at what we did, but also what others did as well. So we're not just kind of looking at, what are the outcomes, what are the impact, which I think are important, but it could lose sight of some of the, if you like, in some ways, equally important aspects of what we do.
Well, I think that's very pertinent to Mike's report, who's going to really take us through the highlights of the RGC meeting, because I think he can almost answer some of Kay's points sort of on the spot, because and there are a number of sort of case study like slides in Mike's report. So, unless colleagues have any other questions on the Jennifer, you had one.
I really like the report. Thank you so much. It's terribly informative, and I always like more rather than less data, but there we go. Just the first obvious point, the underspend. And a lot of that is because of staff pay, isn't it? Because of... Can I just... It's just the headlines of... Is this because it's just very difficult to find staff? Is it because our bar is very high in hiring staff? What, can you just unpack that a little bit more? The 24 million under.
Shall I just come back on that one, Michael? I know Anna's trying to come in. The majority of the underspend is related to staff costs, so we are not at full establishment, therefore the money that we would have paid to people is a legitimate underspend against that. I think colleagues on the board will be aware that we've recognised, or we set what our establishment would be. We set out a plan to recruit to it. We got so far last year and then seemed to stall in terms of being able to attract talent of the right calibre, and we were very clear about the bar that that is appropriate to come in. This is a difficult job, as Andrea said, and we want people with the right skill sets, the right capabilities, the right confidence and the right mindset to be here. So we did feel that we'd got so far and then seemed to stall in attracting people of that calibre. We took time to reflect on where we were looking, how we were looking, the messages we were putting out about CQC, and actually brought that process of attraction of people to CQC back in-house. And I think what you've seen in the months since that happened, since October, is a real energy behind it and a real sense of actually getting messages out about the positive things that CQC is here to do, the mission, the purpose that Andrea talked about. So what we have now, we had a target of 600 to recruit to by December. In terms of inspector numbers, as of the 8th of May, we'd hit 385. So we're going to be, by the end of this month, I would say 2/3 of the way through that target. So that's very encouraging. It means that as we go into 15-16, what we were going to do already in terms of managing our finances very tightly and actually understanding far better our cost base becomes ever more important, because we're going to be getting closer to establishment. So the likelihood of an underspend diminishes considerably as we get towards that number. So I think it's good news. The bar is high and we're looking, getting our messages out differently. And that's proving very attractive to people in terms of wanting to come to us.
I mean, that's good. I mean, we may want to closely, if that's such a major element of underspend, that's clearly, I know we've been back over this, haven't we, as a board, the inspectors' numbers, but also the analyst numbers, which are much smaller. But that's correct. Thank you. Can I just ask another? On the page number 20, the hospitals section, total locations regulated 4,241, and I know elsewhere in the document, in the next paper, there's a slide set which says total locations at 2,665, and then obviously this table, this graph refers to those where there have been people haven't met more than one standard, so that will be a subset. But Mike, can you tell me the difference between the 2,665 and the 4,241? And also the other thing is, that's question one. Question number two is, when we see these figures for hospitals, there's such a heterogeneity here. Some of them are NHS acute, some of them are specialised, some of them are sort of single clinics with no beds, some of them are independent, some of them, etc., community. So I don't know whether it's possible to say a little bit more about all of those that are not meeting the standards. In which of those buckets are they? And
first of all, about the different numbers, it's the 2,600 figure that I normally recognise, but all.
Yeah. Just on the 2,665 appears later in the RGV report is acute and community only, because that's the, if I remember, we didn't take the mental health component Just looking down the list, it looks like it's acute and community only, certainly, whereas that would include all the mental health providers, which I suspect is the difference.
Oh, so the 2,000.
If you're comparing it to slide 3 on the
Yes.
RGV deck,
So there's almost 2,000 mental health.
there's certainly a difference there, and there are a lot of locations for mental health.
I
Remember, it's
see.
locations, not providers.
Okay, that's great. Thank you
I
very
suspect
much.
that's the difference.
But to kind of split that off, I think, into, you know, what kind of hospital, because hospitals are such a basket, isn't it? 'Cause
It is, and one of the issues here is that, of course, with a lot of these sites, they may put one compliance action right, and then there is another one comes along, so that they have technically been non-compliant for over a year because there has been some long-standing non-compliance. What we are doing about this, Jennifer, is I have asked each of our heads of inspection through our deputy chief inspectors to come back to me with an exact list of all of those, the 303 that are non-compliant, so that I can give a complete report on that and what action we're doing. I've got this from some of the heads of inspection through already, and they are all being tracked, I can assure you. And in many cases, what's happening is that we know that we are going to do a comprehensive inspection, let's say in August or September, and so we have made an active decision that that's when we will follow them up. But what we need to be able to do is to demonstrate that to you as the board.
yes, or give a flavour of how many are acute hospitals.
No, we will do that as well, and we will certainly have that for the board away day in July, because I think that will be an important component of it.
Thank you. And then, sorry, I was reading this far too closely. The other is the risk register right at the back. I wondered on the first page of the risk register at the bottom, SR02, the risk of harm to the public if CQC does not take appropriate action. I wonder whether one of them... Well, actually, no, maybe I'll revise. I just wondered whether some of the mitigating actions in how we are seen is whether or not is our approach in the media to be... How often we review... Maybe it doesn't relate to this risk, actually, so probably should take that back. But my question is on the risk register, it's not just that we act, it's also we are seen to act very obviously in the media, mindful of Andrea's performance on the Today programme, which is excellent, thank you. Whether or not, I didn't see anything in the mitigating actions about media and strengthen the media, which is quite critical, I think.
I think that is a good point. I think the Audit and Governance Committee is going to be taking a new look at the risk register at the beginning of June. So I think, Sandy, if we can mention Jennifer's point to Paul. Anna, we have a slight constraint because, of course, we want to hear from Mike, but Dr. Kirkup is going to arrive. I'm not quite sure.
10:30.
At 10:30, whether he's being brought in or...
John's going to meet and greet him and escort him in, so I think John will appear with Bill when he arrives.
Excellent. Anna,
So I'll be as brief as I can, Michael. I just on this question, I wanted to say something about enforcement, and just really to agree with what I think Lewis is saying, which I think is really important in the context of the way that we're going to look at performance, because there are two very different questions and the answers to them could be quite different. One is, does the new approach that we've adopted mean that we are, as Lewis said, removing the worst of quality in a protective space? The other, which is the much more difficult one to answer, is whether or not we're improving quality. And I think we need to be really careful that we don't say that we're improving quality simply because we're taking the worst out of the system. So I think being focused on both of those as different things is really important, because maintain the sustainability of the current approach to inspection, with all the costs that are there, it has to be justified by a positive answer to the quality question, actually, because that's the kind of long-term approach. But so that's just an observation. I wanted to say one other thing about inspection final reports, and don't have to have an answer now, but on page 28, where there's data about the extent to which we're producing reports in a timely fashion. It looks like on the right-hand side there's a plan in place for adult social care and hospitals, but not for primary care, in order to remedy that. So I'm assuming that's simply been missed out, and if not, it would be good to know that a programme is in place, because same issues apply.
Steve.
I'll be brief. There is obviously a plan. Well, obviously you don't know about it, but obviously there's a plan. It's actually more complicated than looking at just, say, a 50-day turnaround of a paper, because we've moved to publishing all of our reports, for example, once a week. And also now, after factual accuracy checks, the reports now come back to us to look again at the national panels. So a proportion of our reports have been delayed by a few days because of the process we go through. And we are fast-tracking those of practices which are inadequate and have a problem. So, in fact, we're prioritising some reports and others are having to wait a bit longer. So it's more complicated than actually looks like on a graph.
Thank you. I think if we take Anna's first point, I think Mike, again, although there's less time, I think hospitals are a very good example of how we can respond to Anna's concern, which I think is absolutely right, that it's, as I understand it, it's not just a case of rooting out bad care, but ensuring that the overall quality of care improves. So, Mike, if you can take us through the RGC report, just one point for members of the public. Inevitably, there's so much involved with CQC that is highly granular that we can't cover at a board meeting. There's just too much detail, and so we've set up committees to take some of the detail out of the board meetings, so the board meetings focus on either on items that are immediately important or are need airing quickly, and the committees deal with the detailed work. But of course, the committees themselves then report back to the public, and Mike is going to give us an example of this. But the whole of the document that Mike brought to the Regulatory Governance Committee is in the public board papers.
Thank you very much indeed, Michael. As you indicated, it's quite a lengthy report, and we discussed this in detail just over a month ago at the Regulatory Governance Committee, and I think we spent at least an hour and a half on it then, so I won't do that again, but I will hopefully give you some highlights. What the report attempts to do is to look at each step in our process, identify key issues at each step, and then say what we are, the action that we are taking to improve each of those steps. And then from about slide 17 onwards, it looks at end-to-end issues. The big questions: can we detect variation in quality between trusts and between services? Are we being consistent in our approach? Are we missing important quality failings? Are we maintaining confidence of stakeholders? Importantly, in view of the previous conversation, are we helping to drive improvement? And then what about our own process, and how is that improving? Maybe if I just concentrate on those sort of larger issues, first of all, can we detect variation between trusts? And board members will be very familiar with this. I think there's absolutely no doubt that we can, and we do. And for example, at slide 18, we show two trusts that have now merged to become one, Frimley Park and Wexham Park, and the difference between an outstanding and an inadequately rated trust is very, very clear. But what that also shows is, even within a hospital that we've rated as inadequate, there can be services that are working really quite well, such as children's services at Wexham Park. So I think that there's no doubt that we can do that, and we then also show that for community services, but giving Liverpool and Birmingham as two examples there. The range there not being as wide as we're seeing in the acute trusts, and we can now do the same with mental health trusts, but it's just not, that wasn't the focus of this particular meeting. We'll bring that back to RGC at a later date. Consistency, we have always said, is our greatest challenge. That requires depends on recruiting the right people, training them, gathering the right data, getting our inspection methodology right, and also getting our report writing and quality assurance processes right. And I think what we're doing is working on each and every one of those steps, and every one of them is moving in a positive direction. The question of are we missing things, we can miss things, and this is on slide 25, we can miss things because we don't get any people telling us about problems within a trust, or there's nothing flagging on our data systems. We could also miss things if we got things in and we didn't respond to them, or we could go in and inspect and still miss things when we got there. And it's probably too early to tell about all of those, but what we are doing is making sure that because we have relationship owners with each of our trusts, that we are tracking what's happening at each trust, and then making the decision as to whether we need to go in immediately to respond to that, or whether it can wait till our next planned inspection. The issue of recruitment, which has been a major one over the past 18 months or so, this really is an improving picture now. There's still a way to go. We're still only at about half the numbers that we would want to be in the hospitals directorate, but the new recruits are coming on board, and I think we can all see light at the end of the tunnel there, even if we're not up to our full numbers there. And then in addition to bringing in inspectors and inspection managers, we're also testing out a new group of inspection assistants, and again we've had a reasonably good response to our advertisement for those, so we're hopeful on that. The next big question is, are we maintaining the confidence of our key stakeholders? And we assess that through doing a provider survey, some of which has actually been reported in the quarterly performance report anyway, but there's more detail here about hospitals. In general, that we get quite favourable results from providers, but on top of that, we do a lot of work listening to individual providers or groups of providers. So, for example, David and I had a meeting with NHS providers and 5 or 6 different trusts earlier this week, hearing their feedback, and we do take account of all that in terms of improving our process from here on. Then the big question, does this lead to improvement? I think we can say we have got some examples of where it does. Perhaps the most obvious example are the special measures trusts, the ones that went into special measures 2 years ago, or almost 2 years ago, July 2013. There were 11 of those. 6 of those have now come out of special measures. Now, clearly, we're not claiming the credit for having done all the improvement, but what we are doing is working very closely with Monitor and TDA, and a conversation I had with TDA colleagues just yesterday was they were saying the focus that we can give to them through our reports of saying these are the services you really need to focus on, this is where care is inadequate, or this is at the well-led domain, you really need to focus on governance or whatever it may be. Those are really helpful to them in terms of the support that they then give to trusts. We've also flagged on that business of improvement that the special measures trusts, this is an analysis done by Dr. Foster, those trusts seem to have had a more rapid change in their mortality than the other trusts. interestingly, it's not only the trusts that are at the bottom end of the scale that we see improvement. Talking to the two trusts that have been rated as outstanding, Frimley Park and Salford, they both have told us that they are sure that they have improved quality further as a result of our inspection. So I think it's across the board. One of the things that I would plan to do in advance of the July away day is to compile more evidence of the smaller improvements that have been made at other trusts. And then the final point really is the one about how do we improve our processes further. We know that, well, we firmly believe, and providers tell us, that we are a great deal better than we were 2 years ago. In fact, those trusts that have had a comprehensive inspection twice over, including both Frimley Park and Salford, have told us that we have improved over the last year. So their second inspection was more robust, more challenging, but better than the first inspection. So I think we are improving, but we know we've got a long further to go. We've recently held a Directorate Away Day, followed by a meeting with my heads of inspection and DCIs, and we are now setting about improving each step in the process. So Ellen Armistead is leading on improving, or working on the recruitment, training, induction programmes, and we're doing that with academy colleagues and HR colleagues, and the whole business of better managing our staff. Ted Baker is going to take a lead, working with intelligence colleagues, on looking at the pre-inspection and how we can get better data coming into our inspections. Heidi Smoult is going to look at the inspection process, and in particular looking at individual core services to say how could we, for example, improve our inspection of maternity services or end-of-life care services. And then Paul Lelliott is going to take a lead on the post-inspection phase, the report writing, but also the National Quality Assurance Group meetings. And these things are not entirely separate, as you can imagine. So they overlap, and the four Deputy Chief Inspectors will work together on all these points. And obviously I will work with them, and I will take a particular focus on what we were going to do from 2016 and beyond, because by this time next year we will have completed our acute hospital and NHS inspections, and so we need to think how we want to modify and take that forward.
Well, thank you very much, Mike. I think because most colleagues were at the meeting, we won't have any questions for Mike. We're very privileged to have Dr. Kirkup with us today. And in a way, it fits very well that Dr. Kirkup is going to talk to us right after Mike's report on our inspections, because, of course, there is a section in the, if I may call it this, the Kirkup report on the CQC. And Paul, I think, after we've heard from Dr. Kirkup, is going to run through the actions the CQC is now taking as a result. Although we've never met, I did say at a previous board meeting that I thought your report was an outstanding example of what a report should be like. But I think for us it had the special relevance of this forensic look at the importance of culture in a hospital, and of course the clash between, or the issues between the midwives and the obstetricians. And also, I think, very important for us was the point you made about data, which is that what looked like a series of individual tragedies really were linked, and they were linked, in fact, right back to this issue of culture. So it was I have to say, from my own point of view, an excellent report. It was also brilliantly written. I mean, I think it was a riveting report to read. So we've been looking forward to hearing from you. So I think over to you.
Thank you very much for those very kind remarks. I'll try and almost certainly fail to live up to them now. I just would like the chance to say a few words about some of the features that led up to the report, and some of the things that lay behind it, if that's okay. Because I don't want to sort of go through the findings and the recommendations and all of that. I'm sure that to the extent that you are interested and you think there are things in it for you, you will have done that. So I don't want to rehash that. I think important to reflect that what actually led to this was the actions of some very unhappy but very determined and very active families who knew that the explanations they were being given were unsatisfactory. And it took remarkable persistence on their part to continue their efforts against what seemed to be resistance from every quarter to sustain the case that they weren't happy with what they were being told, and that in the end that led to the setting up of an investigation via various rather tortuous routes. Initially it was commissioned by the SHA in the last sort of dying throes of its existence, and then it got transferred briefly to NHS England, and then it got transferred to the Secretary of State for Health, who sort of took it over and said that we would have something called an inquiry in public. The snag about that is nobody was sure what an inquiry in public actually meant, so we had to work quite hard to reinvent some rules and set up a system which did offer the opportunity for families to act as observers at each of the sessions that we had, whether they were meetings of the panel or whether they were interviews with witnesses. Family members could be present, and they took up that opportunity to a variable extent. Initially, they were very keen to do it, and then I think having satisfied themselves that this was a robust process, obviously people had other commitments. And also, I think it's worth reflecting that both they and the interviewees were in quite a tense and often difficult situation. The families were listening to explanations about what had happened to their lost loved ones. They were listening to explanations as to why they hadn't received satisfactory responses when they had asked the questions. Equally, of course, those people being interviewed were very conscious that sort of sat behind their backs while they were talking, were people listening and possibly being quite critical of the things that they were hearing. And I think it's to the great credit of everybody involved in that process on both sides of that table that it worked as it did work, with great dignity and great composure. The families behaved themselves impeccably, and equally the interviewees pitched up and for the most part were very honest and very frank in the responses that they gave, and that's to their credit too. I said for the most part, that doesn't involve any previous or present members of this organisation who, to a person, we felt were nothing but helpful. And I'd like to thank them for that. We went through a review of 15,000 documents and we interviewed 118 people, everybody but one of those who we invited to attend. The main findings, you know, relate to the dysfunctional unit, the culture in that unit, the infighting between actually not just the obstetricians and the midwives. We mustn't forget the paediatricians. I sometimes am challenged about whether there were any other groups involved in that, and I think that the only ones who were involved but who didn't get involved in the shenanigans were the anaesthetists. But every other professional group, unfortunately, found themselves unable to talk meaningfully, unable to sit in the same room sometimes. And that led to a whole series of clinical failings that are set out in the report. I think most significant of all is the failure to learn. I think that the most distressing thing of all was that you know, we all accept the fact that healthcare is a risky business and that errors occur. And in fact, most of our families volunteered that to us before we started. They all understood that too. But the contract is that when that does happen, staff who are involved in it are honest and open about it, and most of all, they learn from it. And that was the contract that we found was broken and was the most shocking finding of all. The first incident happened in 2004. Our impression, our very strong impression, is that at that stage, although there had clearly been some drift in the operation of the unit, it would have been relatively straightforward to have put it back on track at that point, had that first incident been looked at properly, been examined properly, and had the lessons been learned from it. As it was, they weren't. The problems repeated themselves in 2006 and 2007, and then unmistakably came to light in 2008. Unfortunately, because of the subsequent series of failures from trust board level, who were utterly focused on becoming a foundation trust, right through all of the other organisations involved, including, as you'll be very well aware, this organisation in its previous incarnation, about which we have been unremittingly critical. Nothing serious was really done to correct this until around about 2011. And that did not, in our findings, bear fruit until around about 2013. And unfortunately, half of the avoidable deaths that we discovered at Morecambe Bay happened after 2008 as a result of the serious missed opportunities. You've referred, Chairman, to the major challenges, recognising and eradicating organisational cultural problems. Recognising them is hard enough. Eradicating them when they have become so deep-seated as they had become at Morecambe Bay is even more difficult, I think. I think that one of the most significant sort of single things that we were told relevant to this organisation is in response to a question about how was it that people had remained unaware outside the Trust of what was happening there for so long. The Trust were very good at telling us what we wanted to hear, and we wanted to believe them. And that was absolutely credible. I'm sure that absolutely reflects how it was. And I recognise the temptation. I mean, when we looked at how the services were functioning there, we could feel the great expectation, the weight of expectation on us to find that, yes, there had been problems, but actually they've all been addressed and they've all been sorted out. It's what you want to hear. And we consciously resisted that, but we recognise that it's very difficult to do that under the circumstances that you're operating in at the time. I think that the organisational culture thing, clearly every single system lined up in the wrong way at Morecambe Bay. And so it should have been easier to spot from the outside. It should have been it was easy to spot at Trust Board level, but they had other priorities which they allowed to dominate entirely how they presented this. And how they presented it was to seek reassurance at every turn for themselves and for external organisations that everything was okay. I think what bears in on me, though, is that there are, I am sure, other trusts around the country that have islands of comparable culture. And there aren't, I hope, any where the whole thing, all of the James Rees and slices of cheese line up exactly so that there's a hole goes right the way through, as happened in Morecambe Bay. But I really do think that there are some that will have a few areas like this, and a few that will have more. I think that the other challenge that I would perhaps highlight is you referred, Chairman, to statistics and the lack of perceived linkage between the 5 incidents. I think there's another issue about statistics as well, which is that both the Trust and external organisations, almost at every turn, used high-level statistics like perinatal mortality rates to reassure themselves that there couldn't be a problem. And that was grossly misleading in the case of Morecambe Bay. These are a small subset of perinatal deaths that we're talking about. They get lost in a bigger number which really aren't much amenable to healthcare, amenable to different kinds of intervention, but not healthcare as such. It was clear that the overall figures were misleading at Morecambe Bay. So I would suggest, and we have recommended in the report, that we pay some attention to trying to pick out from the headline overall numbers a smaller number, for example, intrapartum stillbirths, which are very indicative of healthcare. In fact, I was tempted to say that they should be a never event in intrapartum stillbirth. A normally developed, normal baby that goes into labour healthy and comes out at the other end dead should not be happening. It should be treated as that. I was persuaded that the last thing the system needs is yet another never event, so I didn't. But I still think there is merit in treating them in that sort of way. As you know, we've made 44 recommendations, 18 for the Trust, 26 for the wider system. I've identified in there who I think are the lead agencies, but that wasn't meant to be an exclusive list. So I don't think, if CQC doesn't appear in the list at the end of the recommendation, it doesn't mean to say I don't think you have a role in there. In many cases, I'm sure that you do. And the two that I would perhaps just pick out of that 44, clinical and non-clinical leads, their duties and expectations. We were very struck that nobody in the trust seemed to have any idea of what the duties and expectations were of a clinical lead, a clinical director, for example. That makes life very difficult for everybody. It applied as much to the people who were being led as to the leaders, but on both sides of that relationship, it was a real problem. And secondly, that the complaints system, we didn't hear a single good word about it from anybody, and I don't think that's an unusual experience. I think that is said extremely widely, and I would be keen for that recommendation that it really does need to be looked at again, not to be lost. And with your permission, Chairman, I'll leave it there, but delighted to take any questions that anybody might have.
Well, thank you very much. I'm sure that all colleagues around the table have got questions, so who would like to? Mike.
Bill, first of all, thank you very much indeed. I absolutely echo the Chair's comments about the quality of the report and how useful it will be. And I think that's both at a local level where we as CQC will monitor the progress on recommendations 1 to 18, and indeed, as you probably know, we are planning to go back in and re-inspect Morecambe Bay with a comprehensive inspection within the next 2 or 3 months. But we've deliberately timed that so that some of the actions that you've said should be done by July, we can actually see whether they have, and that will come, of course, into our assessment of the well-led domain. At the trust. So we are on the case there. And then in terms of the other recommendations, a lot of them we do see ourselves as having a role in, and we are very happy to have that role. Specifically, you in terms of the clinical and non-clinical leads, I agree with you. I think that would be very useful if we had descriptions of what those roles were more. It would help us when it comes to assessing the well-led domain at a clinical core service level. So yes, we will contribute to the discussions about that. There are some aspects, for example, that we already attempt to do in our inspections, which is, if we have found a whole lot of failings either on safety or on caring or responsiveness, are the clinical leads and non-clinical leads of that at the service level, are they aware of those same failings? Because the first step is, are they aware? The second step is, if they are aware, are they taking any action? And if they can't take action at the local level, have they escalated it? And that might be either escalating it to trust board level or escalating it to the commissioners. And those are things that we will be trying to probe, but those are only some of the things that we will be looking for. And is there a vision and a strategy for the local service as well as for the trust as a whole? And so I think I'll stop at that point, might come back later with other points, but I really welcome the report.
Lewis.
Hi, Bill. I think, the first thing to say is I thought it was a really excellent report. I think everyone's saying that, but it's worth repeating. There are various reasons why. I had a concern about it, which is how the system might respond and maybe has already responded, which is it's very easy for the NHS as a whole to say, this brilliant report, but it was about maternity, then nationally maternity to say, well, great report, full of excellent things, but it was about Furness General. And then at Furness General, for them to say, well, it was a great report, but it was about that particular group of nurses who were there at that particular time. And so my concern is the potential of the system, the inertia of the system, and the denial in the system that allows us all to say, yes, but it's not really quite like that across the system. And yet many of the things that you identified, I think one of the great strengths of the report was that when you talked about a dysfunctional unit, you It's very easy to say the word dysfunctional, although in mental health we say it all the time. But to define it in the way, so there were some very clear components of being dysfunctional, which were not at all unique to maternity. And so the possibility, therefore, that they might be picked up elsewhere, and this is, I suppose, the point for us, is certainly there, and certainly, and the risk that they might develop in the way that they did is also there in the broader system. So, what I want to ask you is what your impression is of how the broader system has responded so far, not just the Royal College of Midwives, but although maybe including them, but also the broader system. Are people recognising, in your view, how this is a universally applicable set of findings? And then alongside that, for our sake, I had only, it was such a comprehensive report, I had only one question at the end of it, which was the sort of prequel question. What happened before? What happened to get us to the point that you started to describe? So 2004 is a pivotal date, but what was happening before that that provided, maybe in retrospect, but provided the early signs of those 5 components of being a dysfunctional unit? Because from our point of view as an inspectorate, that maybe is a critical question. And then if I'm allowed just one reference, you mentioned complaints. I just would welcome, and we are constantly in this dilemma over, well, it's not a dilemma, we are caught up in a system in which the balance of how to deal with individual complaints and how as a system we deal with evidence of a unit going wrong. We are constantly trying to balance that, and our role, as you know, is not to deal with individual complaints, but it's a common discussion here that leaves us in a difficult position in our public presentation, because people quite reasonably think that if we're interested in the performance of the organisations, we should use the individual complaints more, maybe more strongly. I'll stop there.
Thank you. How the system has responded so far, I think you are absolutely right, and I think there is evidence that there is a desire to localise this in both senses of the word, A to Furness General and B to maternity services. I made a recommendation immediately following the one about a review of maternity services that said these problems aren't likely to be restricted to maternity services, and we should think about them. I was specifically concerned about the context of a small, isolated, not necessarily geographically isolated, but clinically isolated unit where standards can drift. And although the recommendation for a national maternity review has been picked up avidly and is motoring at full speed with Baroness Cumberledge, the other one hasn't, and I have no indication that anybody will be picking that one up. I have had a strong response after a bit of initial prompting from the colleges and the GMC and NMC and so on, and I think they are very actively engaged, and I'm very pleased with the way that they're actively engaged. Bit of a black hole as far as NHS England is concerned. That may just be timing, and I may be still waiting to hear from them, but there's a bit of a lack of indication at this stage that there's a strong response from them on it. The prequel, the short answer is I don't know, because the terms of reference started in 2004. Of course, we picked up some indications, and the indications were that, as you know better than I do, these problems don't develop overnight, and there must have been knowledge amongst the team themselves that they were not functioning at an adequate level. But given the amount of denial that went on from the team, the teams, because you can't call them one team, and unfortunately there were at least 3 separate teams, that there were any problems, persisted long after 2004. So my supposition is that they would have had knowledge that things were not as they should be pre-2004, but they were still locked into a denial mode for long after that. And that, I think, brings us back to the role of clinical leadership at maternity unit level, clinical director level, I think. I agree with you about the relationship between complaints and systemic issues, that they are surely a rich source of information about how the system is operating locally. There's been a recent report this week from the PHSO about end-of-life care, which I think illustrates that very well. And it seems to me that part of the difficulty of the system is that we're set up with a bit of a brick wall in between the two sides, the systemic side and the individual complaint side. And that where, I think to her credit, the Parliamentary and Health Service Ombudsman at the time tried to make a hole in the wall and tried to get some sense that here was a systemic issue that should be handed off, it all went horribly wrong. So that isn't a very good precedent, but I'm sure that we could do better.
Jennifer.
Thanks. It's really a question for Mike, actually, and you've kind of responded to some of this. It's a general question about our well-led domain and how far it really penetrates down into the clinical domains, just as you describe. And I'm just mindful of a comment that was made. We were all at a dinner, a few of us were at a dinner on Tuesday night, actually, with some of the chief executives of trusts who've been done by us, as it were. And one of the comments there, which we didn't pick up, was about the well-led domain and how deep it really was. But so it's really how we are developing that, and not just ourselves, but also with others who might, such as not just the colleges, but also, I don't think the colleges necessarily have a view about clinical leadership, a united view, and also whether Monitor TDA have a view and how far they want to go down and think about management at that level. But it's quite critical, isn't it? So I guess it's a question about our onward development of the well-led domain that it might be worth just for us to air. And the second point was also about another comment made on Tuesday night as well at this, which was some of the chief executives there, if I've got this correctly, were interested in us not just asking hospitals for information on XYZ, but also to be in more partnership with them to say, well, what information do you collect on this kind of area? For us to then get a view about actually how much visual acuity they have into the quality of care, into the nether regions of their operation. Because obviously some have 20/20, well, nobody has 20/20 vision into clinical quality, I would say, but some have more acuity than others. And for us to know that, for a start, is quite important. So those two questions. Thanks.
Okay. First of all, our assessment of the well-led domain. I think it has moved on a lot in the last year. Do I think it could go further? Yes, it should. We've been working, as you know, I think, with Michael West and the King's Fund on this, and also closely with Monitor. And we are trying to look at well-led at the trust level, at the service level, maternity or medicine, whatever it may be, but also at the ward level as well. And clearly, we do look at the quality of the leaders. That is an important component, but it's not the whole thing. We do assess whether there is any vision and strategy, and whether that vision and strategy is known to anybody else apart from the leaders. Have they shared it? The governance arrangements are obviously very important. Would the trust board know where the problems were? And we certainly, if we find problems and they're not aware of it, that is an indication that they're not well led. We're very fortunate, as you know, in the hospital sector in having a staff survey, and the staff survey, I still maintain, is the most useful survey of the lot, in that when that goes off, we really do need to be worried. Obviously, that doesn't get us down to the individual service level, but there, I think, that's where focus groups can be very valuable. We can hear that there are problems in, let's say, maternity or whatever, and we can then probe more deeply. And we can, of course, ask to speak to midwives or obstetricians or paediatricians at that point. I think our general approach is a lot stronger than it was. In terms of working with the colleges, we do, in advance of any of our comprehensive inspections, write out to colleges to ask them whether they have any concerns or know anything about a particular trust. I think there's bringing it back to your report, Bill, the point about when a college has done, or any outside agency has done an invited review, we should know about it. Actually, I would go one stage further perhaps and say at the outset, if they have commissioned an external review, we should know about it, because they won't have commissioned an external review unless there was a problem. So even having that flagged to us, and we've had other examples of where external reviews have been commissioned, but we're not necessarily the first to know about them. And I think I would like to make that an expectation on trusts, that they should communicate that to us.
Would you like to?
I absolutely endorse that. I wish I'd thought of making it a requirement at the outset as well. You're absolutely right, of course.
Robert.
As one report writer to another, can I firstly congratulate you and secondly commiserate? You've done a tremendous job, and the depressing thing, it seems to me, is that what you found echoes so much what was going on at the same time in Staffordshire. And that event, nothing else demonstrates how this isn't a problem about maternity. It's not a problem about an isolated hospital in the north of England. It's about culture, and it's about the system. So thank you for that. And I'm interested in the comments about obviously about the reaction of the system to your report. And what I'd like to just focus a bit on is the issue around complaints, because your report, like mine, started off in reality with an aggrieved group of people who had not received any satisfaction for quite egregious harm done to them or their relatives. And my own feeling, and that must be yours, is that we just still do not pay enough attention. When I say we, the system generally does not pay enough attention anywhere to the complaint of the individual and the significance that holds for the system as a whole, as well as the individual. And people are passed from pillar to post with no one looking into their issue. Can I, obviously, you've asked for a review, and that I think is welcome. All I would caution is that I now have a slide in which I add, and your report's now on it, I add a picture of all the reports that there have been since the Kennedy report, all of which are followed by reviews, more reviews, and one wonders what then happens, and I'd like your comment on that. But and how do we change that from things that are continually discussed and everyone agrees that something must be done to actually getting something done? But about complaints, I wonder if you have any reaction to the report of the Public Administration Select Committee, and which came out just before the election. And the emphasis there on taking a more safety investigation approach to incidents, and whether that is something that shouldn't be imported into to complaints where they involve issues of harm, in the sense of trying to establishing what it is has actually happened at the earliest stage possible, so one can then assess the significance of it in a way which perhaps we don't at the moment. We either go into a defensive mode or we dissolve into personal feuds, recriminations, and we never actually get to the bottom until it's far, far too late to what actually happened and what could be done to stop that happening again.
Thank you very much. I really appreciate the comments, although the phrase "standing on the shoulders of giants" springs to mind here. I pick up the point about complaints first. I couldn't agree more. I think that one of the very distressing features of the aftermath of the publication of the Morecambe Bay report was the number of families who took the opportunity to come and talk to the panel for an explanation of what had happened to them. Often 6 or 7 years previously, in one case 10 years previously, and that was, they said to a person, the first chance that they had had to sit down and have somebody explain what had happened and what had gone wrong. And that is an absolutely lamentable situation that shows how complaints have gone off the rails and how they are treated as something to be defended against, something to be delayed as far as possible, something to be avoided, but not something which actually is a follow-up part of the care of that patient where something has gone wrong. Yeah, I called for a review of complaints, and there have been very many of them in the past. What I really meant, of course, is that we should have a reformed system of complaints. But as I didn't have a clever answer off the shelf as to what that reformed system should look like, the shorthand, I think, is it needs to be reviewed. I don't think, and I suspect this lies behind what you said, that necessarily means a very formal review that will take a long time and come up with some worthy recommendations that aren't operationalised. I think what it actually means is some people who can design a better system, sitting down and doing it quickly. But unfortunately, that's one of the relatively circumscribed but nevertheless definitely present black holes in the response so far. I haven't heard a word on that.
Jennifer.
I just got time for a quick question. In all the evidence and review that you did and all the recommendations, I just wanted to get a handle on to what extent clinical competence itself, isolated from toxic relations and organisational sort of mismanagement and all the rest of it, how far clinical competence was really a factor here. Because it's really stark in the report, isn't it, that some features of sepsis weren't spotted. And some of our work at the Foundation is also showing that too. So how big an issue is that compared to the just toxic relations in your mind? And really, how far should this? I know that's not us necessarily, but how far do you think that really that pedal ought to be pushed much further in the NHS?
My sense is that there were certainly failures of clinical knowledge and the way that was put into practice, but they were much more insignificant than the problems of the approach and the failure of teamwork. That in most instances, I suspect, I can't prove this, but I suspect that the knowledge was actually there, but it was suppressed because it wasn't felt to be appropriate. So I don't think, for example, that a midwife would have not known the significance of a lowered, I beg your pardon, temperature in a neonate. I don't think that midwives who described failing to monitor progress in labour adequately knew that was, didn't know that was part of the duties of a midwife. It's so fundamental to what you do. I don't think that they could have not known that, but that because of the culture, because of the approach, because of this pursuit of normal childbirth at any cost. I must stress at this point, people often pick me up on this and say that's a pretty striking phrase, but do you really mean it? No, I didn't invent that one. That was told to us. That was what one of the midwives described the situation as to the panel. They were pursuing normal childbirth at any cost. And that actually it was more important that they suppressed that knowledge because it didn't fit with the agenda that they were pursuing than that they didn't have the knowledge there in the first place.
Andrea.
Thank you very much, and like others, Bill, I mean, I read your report from cover to cover and found it both a depressing read, but also very insightful. And having managed maternity services in my health service career, kind of sadly drew lots of parallels. But what I wanted to say, and it's as much a message for us as an organisation and the board as for you, is that it is about kind of taking the lessons from Morecambe Bay and indeed mid Staffordshire and actually not thinking that they're localised to a single set of services within a hospital in a particular area in the country, but actually some of the issues that you identified, and particularly the factors that turn a team into a dysfunctional team that has such an impact on the lives of people that they're supposed to be supporting and caring for, you can apply across the whole of the health and social care sector. And it's something for us from an adult social care perspective, and I'm sure Steve would say the same in terms of looking at things from a primary medical services perspective, that we need to learn the lessons from what you've identified as well as what Robert identified, and apply those into our working in social care as well, because issues of competence and capability within teams, leadership, open and transparent and inclusive cultures, and being honest and responding positively to the concerns that people are raising apply just as much in a small care home in any bit of the country or a domiciliary care service. And I think that we will also be using the insight that you provided to underpin the questions that we ask, both about safety but also about leadership, because I think they apply in adult social care as well. So thank you.
David.
Thank you, Michael. Bill, thanks. Thanks for coming today as well. I'd be interested in your thoughts on what your report means for us. The point that you began with about culture and the triangulation, Robert, with a lot of what you said on culture struck me as being hugely powerful. And at the dinner that Mike and myself had with some people, this was to feedback for us. We said, tell us what it's like to be inspected by us. And it was a mixture of chairs and chief execs, 5. It was intimate. It was a good conversation. Some of it was uncomfortable, I have to say. Some of the things he said made me feel uncomfortable. Interestingly, to other colleagues, in terms of the debate that we were having earlier, the so what question, all of them said without fail that they'd improved as a consequence of us going, which was a good thing. But one of the themes that they came out with, 1 or 2 of them said they'd experienced the inspection as people trying to catch them out, feeling that they weren't believed in what they told us. I.e., we weren't believing them. Our style and tone was of, we don't believe you. And this was a problem for them. This was something that we needed to do something about. And I think this goes right to the heart of openness and transparency, and the point you're making about complaints. And Robert, I think it goes to your point about culture as well. So we end up in this position of regulators can be damned when they do and damned when they don't. You can either be too intrusive and you just ask for continuous information to get to the bottom of something, or you can be too light touch and you don't. And I think we focus a lot on our methodology. I think it goes to your question about how do we, what is the message from this about how we assess well-led, I think. But I'd be interested in your point on tone and style, but you've been around for a long time. This is a very wise report in the sense of the kind of empathy that you've got right around the piece, in my view. Empathy for the people that made the complaints, but also I think there's a sense of empathy for the service and wanting to make it better, a passion for wanting to do that. And I would be really interested if you've got any reflections back to us about our tone and style, about how we should go forward. I think this is a big issue for us moving forward, about how we maintain our independence, speak truth to power, as well as actually encourage improvement. It's dead easy to do one or t'other, getting the balance right and speaking for people who are using services. Your point about, there's terrible stories about people who took best part of 10 years to actually get their stories heard, to get an apology is shocking, quite frankly. And but style and tone, I know it's a tough one. I'm not asking for the answer, but your reflections.
Good, just as well. Thank you. I have reflected on this a number of times over the course of writing the report, which. Incidentally, in response to Andrea, it was quite tough to write as well. It was quite a harrowing thing to have to go through for all of the panel, and also afterwards. And I think that it goes back in a sense to the comment that I made about the telling thing that we were told about the trust were very good at telling us what we wanted to hear, and we wanted to believe them. I think that you're probably dealing with a system where. I don't know what it is, 330 trusts or whatever these days. I'm sorry, I've lost count of the numbers. But I mean, 320 of them will be perfectly honest and open and transparent and will want to be dealt with on the basis that you can trust them. But 10 of them won't. 10 of them will be Morecambe Bays that are trying to conceal things and not telling you stuff that's painful. And Mike might want to disagree with me about the numbers, I don't know, but let's stick with that for the time being. And you can't have a one-size-fits-all approach in that case, because if you're taking the sort of rather forensic and rather ruthless approach, which you need to pick up the Morecambe Bays of that era, who were trying to pull the wool over your eyes, then you are going to irritate the great majority of trusts who aren't behaving like that. I'm sorry, David, all I've done is restate your question. I haven't got any further.
So I think, Bill, what we have often talked about, and I think you bring us back to this, is how differentiated and proportionate we can be. So it isn't a one-size-fits-all. And the danger is we treat everybody as if they're not telling us the truth, when your point is absolutely right, people are. And I think that's where we need to develop our skills and apply those skills in a proportionate and differentiated way.
Can I just come in on the point of, I think there are a very small number, but there are a number of trusts that do try to pull the wool over our eyes. I think our methodology, particularly in the staff focus groups and having drop-in sessions for staff when we're on site, I hope and think and hope that does then reveal which ones are perhaps hiding things from us. I remember in one of the KEO reviews that there was a trust where everything seemed a bit too perfect, and at the end of focus groups, one or two staff members stayed behind and said, "You do know it's not quite like that, don't you?" And that put us on to what we ought to be looking for. And at another one, an inspection that I chaired, we got a sense that in the consultant focus group, we weren't getting the full picture. What actually happened was that at least a dozen different consultants found their way to come and talk to us, which is far more than normally do individually. They usually say it as it is in the focus group. But when they're not doing that, if they then come and find us and say, "Can we have a private chat?" And in one case, one of them said, "Can I talk to you on the phone? I don't even want to be seen to be doing that." And that told me a lot about the culture in that trust.
Anna.
Thank you. I just want to wholeheartedly support and welcome your recommendations, particularly around the complaint system. Probably not surprising, given where I come from, particularly in relation to my role at Healthwatch England, which has been calling exactly for that kind of system reform. And one of the reasons is because it seems quite clear to us that problems that both your reports have identified, and which we've seen referenced in a lot of other places, are not just problems relating to the fact that the current complaint system doesn't work well in some places. It's not how some people are applying the system and it's and not perhaps doing it very well. It's actually because the system isn't right. But we, like you, will get lots of sort of support and positive comment for some specifics of change in relation to the complaint system. Well, what about we just tweak it here or tweak it there? And there is, as you say in your report, Paul, a programme of work which the Department of Health sort of brings together to do exactly that, to try and make the existing system work a bit better. But there does seem to be this refusal to take to look at whether the system, or just to, as you rightly say, just do it, to change the system and make it into something which is much simpler and more straightforward, and so more effective for users of health and social care. And so my question is two parts really. One question, one encouragement. The question is, have you got any sense of why it is that that you are not getting a response? I know this is kind of difficult to judge. If you're not getting a response in this area, perhaps it's just a black hole. That's how you described it. But I mean, have you got any sense at all of why people are less willing to look at that reform question? And then the kind of encouragement is, please don't give up on that, because I think, you know, lots of us have been saying that this is necessary. We're still not getting a kind of traction with it, but I don't think we should go away for that reason, because I think it's too important.
Thank you. I won't give up. Absolutely on that one. Why? To be charitable, I guess that at the very top of these organisations is the Department of Health, who have been a tad distracted with political events until very recently. So I've given them the benefit of the doubt that probably now is the time that these things will start to get picked up again. But I will be continuing to ask the question of why not, if it's not. May I just respond briefly to Mike's point about consultants coming and talking to you after or on the fringes of CQC visits? One of the things that struck us very forcefully about the Morecambe Bay setup was that some groups of consultants were actually very non-assertive, if I can put it that way. I mean, some of the features of the clinical practice that are described in the report would illustrate that. For example, midwives changing their minds about an obstetric assessment and saying, no, go away, we don't need you anymore, and the obstetricians just going along with that. That's a pretty non-assertive behaviour for the average obstetrician, I think you'd agree. But my point really is that you will find people will come and do that where you have got a group of assertive consultants. You may not, where you have got people who behaved in the way the Morecambe Bay people did, which was rather to retreat into their shell when faced with these kind of problems.
I absolutely agree with you, and so that's only one line of trying to explore what's really going on, and I think it comes back to looking at a whole range of different sets of information. Have we had any whistleblowers? But if we haven't had any whistleblowers, are there any complaints that, and have we fully explored what the nature of the complaints is? We are doing a lot more now looking into incidents and incident reporting, and so have any incidents that have been reported, and then getting the better metrics. And I think your intrapartum stillbirth metric may be an important one, even if it's not a never event. It's certainly an event that we should be recording and picking up on. So I don't think any one of these avenues will ever get to the truth on its own. But I think by having so many avenues, we reduce the risk of missing things. I'm not saying we eliminate it.
Do colleagues have any other lists?
One of the interesting things about the inspections that and the new regime, which I very much support, one of its sort of curiosities is that on the caring domain, almost everybody does really well. So that's the number. If we were just judging by that, we would identify very little poor care. This raises a question for me about how we identify poor care, because at the moment, sorry to say this, Mike, but at the moment we could almost abandon that part of what we do because it's contributing very little to the discrimination between one trust and another. You can see from the flurry of agitation that some people are wedded to it, but it's a statistical fact that it is not contributing because most people do well. And this raises for me a kind of dilemma here, which is that. So all my career I've been trying to understand things like safety and experience of patients and so on by aggregating the data. And because the aggregated data, that's the only kind of valid data you can get. But it forces us to think that actually that may not be right, that the way that aggregated data smooths out the things that you really want to know, maybe what we have to face and what CQC will have to face. And that will then place on us a greater responsibility to be able to get at the incident which may only be one incident during the course of a visit, but which is emblematic of the things that can go wrong. Not that go wrong for everybody, because the surveys will tell you that it's not going wrong for everybody, but it's sufficiently powerful that it will tell us the thing we really need to know about the care of that patient. And so it's a sort of question for you, Bill. Is how do we? There are obvious difficulties about going by individual cases, the biases you introduce, the unfairness that you might introduce, and yet at the same time the potential to miss what really matters about a service by not doing that is sort of major. And I think we're at that decision point now. So, any comments?
I agree. I think that we saw this absolutely in its kind of most extreme form in Morecambe Bay because of the nature of childbirth, where 98% of the time it's going to go fine, whatever the clinical care is like. The patient experience responses were hugely dominated by people for whom nothing had gone wrong and who didn't have a bad word to say about the same group of midwives, because they were very sympathetic and they said all the right things and all of that. It was only their lack of surveillance for the rare events when something went wrong, in which their practice was aberrant. And so, of course, that led to a lot of the interpersonal conflict that's been a feature of social media and the local scene in Barrow, because an awful lot of women and families were quite resentful of the fact that our families had raised these complaints. They couldn't understand why, because everything had gone fine for them, and therefore they were applying a different set of judgments to the midwives than the ones where something had gone wrong. I think it does come back to complaints, and I think it does come back to incidents. And I think the more that you're dealing with a specialty like obstetrics, where the great majority of it is going to go well, whatever you're doing, the more that's true. Other than that, I'm afraid I don't have any insights to offer.
Well, Dr. Kirkup, thank you so much for... Sorry.
Can I just come back on the point about caring? I feel I need to. Lewis, there is undoubtedly a shift between the caring domain in hospitals and the others. In other words, we have relatively more outstandings, relatively more goods, but we have a few requires improvements, and even on occasions we have inadequate for caring. So there is a shift between that and some of the other domains. Absolutely agree with that. But actually, it is that differential that matters. So where we do call caring as requires improvement or even inadequate, that really matters. I perhaps just say the word Hinchingbrook to remind people that we have rated caring as inadequate in the past. The other thing is that we do have a number of surveys which fortunately correspond with quite a number of our core services. So we've got the A&E survey, maternity survey, inpatient survey, cancer patient survey. There will be soon a children's survey being reported, and I'm even hopeful that we can adapt the Voices survey that's of relatives of people who've recently died to give us more information on end-of-life care. What those surveys do actually show is that the vast majority of people are scoring their overall experience of care as 8, 9 or 10 out of 10. Now, we can have a debate, and I think we should have a debate, as, should it be, before we call them as good, should it be 80%, 90%, 95%, 98%? That's a legitimate debate. But we can differentiate, and we do differentiate between those that are requiring improvement and inadequate. And when they do require improvement or inadequate, what I have asked our inspection teams to do then is to conduct a SOFI, in other words, a direct observation, so that they gather the evidence to justify that statement that it requires improvement or inadequate. So it does discriminate, but it's just at a different calibration.
Well, I think you can see that we could easily take up hours of your time, because your report has raised so many very important issues, but we're grateful to have had the hour today. And I think you've also kindly agreed to talk to all of the CQC, all of our colleagues through this webinar. But just before you go off to do the webinar, I think, Paul, it'd be very helpful, I think, to get our the top line changes or that the CQC is going to make, or its reactions to the particular part of Dr. Kirkup's report which focused on the CQC's role in all of this.
So the lines and a bit of detail underneath them are in the board papers, so I'll not try to go through every one of them. I think it is worth making two overall points. So one is that we've, in light of the review, report, but also beforehand, invested a lot of time and energy right across CQC to understand, and that goes from the colleagues who were involved in giving evidence to the report, and John Forrest, who are supporting them, and people like James Kirkup, of course, and also Anne Ford and Rona and Alex Bayliss and their teams have been trying to think through what this means. I say that because it's important to the earlier discussion about how this isn't just furnace and this isn't just maternity. The other piece I'll say before I just mention a couple of the specifics is that we also have the overarching work on our next strategy. So what we are doing over the next 3 to 5 years from April 2016 onwards, and it's very pertinent to that as well. So we had a conversation that looked, in response to David's point, about what chief executives and chairs are telling us about partnership. One of the big things that we'll be looking at is what the appropriate balance is between the act of site visits, the act of collating all the information that's available publicly and sometimes not publicly from people we can talk to, but also the way in which we can ask more of providers and take a view from them. They have fundamentally an information asymmetry with us. So our ability to understand their best view of care and take a professional judgment on where they then lie on the spectrum of their own understanding of their organisations seems a very important component of the future strategy work. So although this paper covers the specifics of what we're doing in response to the recommendations, it also leads into wider work that we'll be doing. So if I just highlight at the in section 2 of the paper, part 2, part 1 of discussion implications talks specifically about the inspection that Anne Ford will be leading on CQC's behalf. I won't dwell on that. But there are 4 areas where we anticipate being particularly involved for in the recommendations. One is in the investigation and management of safety incidents and concerns. There, we've had a lot of conversation, including publicly at the board, about what our role in safety should be. And we're expecting a decision, now that the election has passed, quickly on where the safety function will sit amongst national bodies. And I think that's an important step before we can finalise then how we enact the recommendation. Fundamentally, if we are the prime mover, if that's the right term, in the safety system, that's one thing. If it goes to an independent body or elsewhere, we will need to flex our role accordingly. The second part is how we work with others in the oversight system, and the point that we just want to pull out from the paper here is the importance that the National Quality Board plays in this, jointly chaired by Mike and by Bruce Keogh, so that the safety is not seen in some way as separate to the rest of quality, but it's absolutely the bedrock of quality, and that's what the purpose of the National Quality Board is there for. There are a number of specific reviews and discrete projects which we will contribute to, and you mentioned the point about information and not relying on more gross measures like perinatal mortality. Some of that we are already able to look at through our Outliers programme, sepsis being just one example of that, but we very much take to heart that point about being able to look forensically inside bigger data sets to be able to spot the real risks and dangers. And finally, on complaints and whistleblowing, with the parallel work that's ongoing through the Freedom to Speak Up review from Robert, and we will make sure that our response covers both the recommendations from your review and from Robert's review as well. So I hope that strikes a balance between trying to go through every single recommendation, but also highlighting the major areas that we'll want to contribute to.
So again, Mr. Rick, thank you very much for coming. It's been very valuable for all of us. Thank you also for taking part in this. I haven't even learned how to use this microphone yet, but thank you very much, and thank you also for taking part in the webinar, which is going to happen now.
Thank you, it's a pleasure.
We're actually going to, we are going to finish by 12, partly because this room is going to be used for the webinar itself, so we're going to be moving somewhere else. But our last two items happen to be the last two, because there always has to be a penultimate item and a final item on an agenda, but they're nonetheless important items. And I thought, Eileen, I think you can probably take it that all the board have read the two papers, but I think it would be worthwhile to highlight what you feel are the key points to in getting the board's approval for the two papers.
Well, thank you very much. I do feel, as I say to Paul, that we're going from the profound to the prosaic here, but actually two very important things that we're looking at. The board will recognise a number of policies have come through, and this is part of a process of CQC, appropriately, as all organisations should do, looking at its key policies, scrutinising them, revising them and modernising them as appropriate. And I think probably helpful to, if the board is comfortable, to take the two together and invite any questions. The counter-fraud policy and response plan has been through an internal audit process. Our internal auditors have expressed themselves content with the way that it is expressed. And I think in practice what we see is we do have a counter-fraud policy that, when it is put into action, works. And I think that is the key test of any policy, is if you have it and it's used, does it work effectively? And I think in terms of what we've been able to draw from our analysis of looking at it, it certainly does. The gifts and hospitality policy was looked at in the context of just making it slightly more accessible. So when I talk about modernising the language, the sentiments remain the same, but some of the explanation, I think, has been made more accessible to people so they actually understand. Oh, I hope the basis is there for all of us to understand more clearly what is meant by gifts and hospitality, and that it's appropriate and proportionate. So it's in that spirit I'd put the two forward. Happy to take any questions, but really seeking board endorsement for the two, Michael.
Right. Do colleagues have any views on these two policy papers, or are they happy to approve them? I think, Eileen, Robert, you're happy.
Yes, I'm absolutely happy with the content. I just had actually a question about the hospitality policy. I think it's clear to me what that's meant to cover, but in relation to staff, it's presumably meant to cover gifts and hospitality offered or received in their capacity as a member of staff of the CQC, all which might influence their duties of that. It's just that I'm not sure I see that anywhere in it, and I wonder whether that's somewhere else. In other words, if you took it literally, Christmas gifts from members of your family, you have to declare, which clearly is not what this is about at all. At least I hope it isn't. Not that some of us would have very much to put down if it was, but that was just a sort of drafting point as to part of the introduction, really.
I think that's really helpful, and we will amplify that. We are just revisiting our code of conduct for staff, from which this will feed, and I think we'll just look at that and make sure the language is very explicit around what is meant.
Thank you. Well, I think that means that the subject to the drafting point, the important drafting point that Robert just made, that signifies the board's approved these two policy papers. We now come to any other business. I don't know if there is any. In which case, if there are any questions from the floor.
Thank you, Chairman. May I express my thanks to the board for taking questions from members of the public. It is appreciated. A couple of questions, if I may. I come from Healthwatch Hertfordshire, and I wondered to what extent the board feel that local reporting to local Healthwatch, that intelligence reaches through to the Care Quality Commission, because certainly in Hertfordshire, a lot of intelligence is received locally about all aspects of NHS services, some good and some poor. Is that data captured?
Thank you. So there's a lot of work that's been progressed over the last year or two between nationally Healthwatch England and CQC to strengthen the way in which CQC can share knowledge and receive knowledge from local health watches. We don't profess that it's perfect yet, but we think it is significantly better. Part of that is us being better about explaining when inspections are going to happen to support local health watches. And first things, you're more likely to share information if you think there's a moment. And the second part, I think, from the CQC point of view, is us simply getting better about our use of information in the round and how we access a whole range of different sources. So as we've brought more inspectors on, and chief inspectors may want to comment on this, one thing we have noticed, of course, is that with the focus on ratings and following up on information of concern that we already have, it can sometimes be the relationship management element with the with other stakeholders that can get squeezed. So we're really pleased to be getting up to our full cohort of inspectors so that we can do all those things that we've wanted to do as well. We're also aware, quite naturally, that different local health watches are different. And in some cases we have stronger relationships, some are bigger and better formed. But the test, I think, for us is that we feel confident that it's getting better as we go along on this journey.
Thank you. The other question relates to complaints, which is the theme of the discussion of the meeting, particularly with Dr. Kirkup. I wondered to what extent the board feel that the Parliamentary Health Service Ombudsman's work, most recently their report on end-of-life care, which is very critical of all aspects of the NHS, really, from hospitals through out-of-hours service and GP services, and also the particular reports which the Ombudsman makes following ineffective responses to patients' complaints. To what extent are these areas picked up within CQC and acknowledged and acted upon?
David, perhaps.
I think Michael have a go at this as well, Michael, but I do think they are. I think you're right about the themes of the issue about complaints, and I think the paper that Paul presented and the detail of that picks up what we're doing about it. My understanding is the government is going to respond to both Robert's freedom to speak up and Dr. Kirkup's report imminently, and I'm not cited on that, so I can't profess to have any inside knowledge, but I think they are going to pick up. But Michael give more detail on precisely how we pick up on some of those recommendations.
I mean, in relation to end-of-life care, we made a decision when we started our new approach to inspection that end-of-life care would be a core service, both in the acute trusts and in community health trusts. And we have been obviously developing our methodology for that as we've gone along. We do see great variation. But between trusts, where some trusts are doing what appears to be a very good job, and that's not just by having a good specialist palliative care team, although that's a very important component of it. It's how is that team then engaging with the whole of the trust. Importantly, and this came out in the PHSO report, how people in the trust are going about recognising the fact that people may be approaching the end of life, and therefore planning with the person for what they would want for the rest of their life. So we do see variation. Clearly, the PHSO sees the tip of an iceberg, but what we are looking at is the totality, and we see variation, and we will go on exposing that where we see it. But we have rated some services, I think, as inadequate on all 5 key questions, Lewis including caring, at the end of life. So that we do, when we pick that up, we will report on it. But I think there's more we can do.
Steve, I should know this, but I don't, and that is whether we look at end-of-life care as part of our GP inspections.
We do across a number of different domains, because often GPs are key to the ongoing care. I think we can do better, to be perfectly honest, as we move forward, because what I'm interested in is the link between the GP and the hospice service, the GP and the hospital service, and when we start to look at more integrated care, looking specifically at a geographical area on end-of-life care will be better, with GPs being a component to it.
And I had I'm not sure if I can ask this, I'm allowed to ask a question, but I will ask one. Andrea, I think consistently hospices are rated good or outstanding. And I wondered, although we just heard a story from Morecambe Bay of how a culture can go wrong, I wonder if hospices also are, or the fact that we rate hospices so highly, is in a way an example of how cultures can go right.
Indeed, I'm sure that's the case, Michael. And one of the things that we are working on with Paul's team is also to look at those examples of outstanding services where we can try and pull out some of the kind of key characteristics, if you like. And actually, the question that Lewis asked Bill was, what were the predicting factors to the 2004 incident that then continued on? What would be really helpful, I think, is for us to look at what appear to be the predictive factors for a good and outstanding culture and response to end-of-life care and other issues from our outstanding reports. And that's certainly something that I think that we would be wanting to do as we showcase some of those services. And I think your suggestion about focusing on hospices is a really helpful one.
Michael, can I just add in relation to hospices that, again, there is objective evidence coming from relatives of the difference in quality of care between hospices, home and care home and hospitals from the Voices survey done of bereaved relatives. This is something I had a particular interest in my previous role, but hospices come way out ahead of the rest, and hospitals come out way out the other end, I'm afraid. And so that is why I think we particularly chose to make it a core service in the hospital sector. But we do have that objective evidence from relatives.
Thank you. Robert.
I'm sorry to take up time, but it is an important point. In relation to hospices, can I just endorse what's been said? And two points. One is, to my knowledge, some of the really good hospices already do outreach into training other services in what they do. But the other point is a more general one, which we see time and time again, that where good things are pointed out, there is a resistance to some of the suggestions because, they are different. And hospices are often thought to be different from other services because, or rather, the way it's put is we are different and therefore we have more problems, which may or may not be correct. But what I would ask is that when we look at something like this, we look at how the lessons can be applied and how we answer that particular question, because I think sometimes the differences are more imagined than real.
Well, I think you've had a very full answer, and I think you can take from this the board is. The board regards end-of-life care as very important. Are there any other questions from the floor?
Good morning, Paul Griffiths from Circle Housing. I've just got two kind of quick questions. The first one, slightly prosaic, regarding the Adult Social Care Symposium happening in July. Just wondered when maybe the learning and potential kind of recommendations from that might be sort of published, and if it is going to be published publicly, so it'll be available. And the second point was just a minor point or question going back to the CQC sort of trying to sort of evaluate its impact that inspections are having. I just wondered if it is, or if it's going to be considered that, for example, in a care home or a domiciliary care provider, if it's been rated inadequate or requires improvement, there will be a follow-up inspection. If the inspector will explicitly ask maybe people who use that service or their friends and families, what has changed since we first came in?
Thank you. I didn't catch your name. I wonder...
Paul Griffiths.
Thank you. David.
So if I do the first and Andrew does the second. The symposium, the reason for putting it in my report and making that public and drawing attention to it today is we will see that as something that we will do openly. And yes, we will draw something together. By definition, anything that we publish as a consequence of that will be after July. So I'd be expecting it by the autumn. I think this is a hugely important issue at the minute, and so I wouldn't be wanting us to delay while we polish the language in any report that we publish. I think we need to move quickly, having listened to people about what conclusions as a regulator we want to draw about that, and what issues we would draw to the attention of others who will have a contribution to make. So, as I say, the event itself will be an open event, and we will publish immediately afterwards.
Thank you. And to pick up on your second question, we will go back into services if they've been rated inadequate within 6 months, and if they've been rated it requires improvement within 12 months. At the heart of the methodology is to talk to people who are using the service, their families and relatives, and staff and other professionals as well. And part of that kind of follow-up review will indeed be kind of teasing out what we'd said needed to be changed and whether that has changed and what difference people can see. We are actually now already going back into some services that we had rated as inadequate and seeing that. So you'll start to see some reports coming through with a reflection of the voices of people who are using services, either telling us that things have changed or telling us that they haven't changed, if that's been the case. Thank you.
Thank you. We have time for just one final question because of this room being used for the Bill Kirkup webinar.
Oh, OK, Michael, I'll be very quick. 2 points, really. I'd like to echo the recognition of David Pryor and whatever, really, to his appointment, but also the way he chaired these board meetings and welcomed people in as well, really. I'd also like to echo the fact that you, again, take questions from the floor and whatever, really. And again, that's something about your lived behaviours, how you live those day after day, because that's not always the norm, really. They're locally also with some national boards, really. If you don't put a question in, it doesn't actually even get, it'll be and I just think there's some things that come from the floor that you might just think of as you do the discussions, and that's about actually taking every opportunity to engage as well. The one question is for Mike, really, in terms of the listening events that we do for acute hospitals, where are we with doing that with community services? Because I still think that those listening events have a role to play but I don't hear anything about listening events for social care. I don't have listening events for GP and primary care and whatever. I know there's opportunities there for that, but I just think it just comes across as a bit of an inconsistency.
Thank you for that question, and Andrew and Steve may want to reply on social care and primary medical services. I think it is easier to arrange them for hospitals around them being at a specific location, and generally speaking, people living not too far away, whereas our mental health services and our community health services often cover 1 or 2 counties, so it is extremely difficult. I think we are constantly looking for what ways we can best engage with the public. I think the listening event is only one of those. And in many ways, we expect with the listening events to get polarised views. What we tend to get are people who are strongly supportive of the hospital or have had very negative experiences. Though both of those are helpful, and indeed it's sometimes the negative experiences that can actually point us in a direction of where we might want to go. It's a bit like a complaint. So we use it in that way. We don't generally use that as the guide to our judgments. It would be only one very small part of that.
If I could just answer from a social care perspective, one of the issues for us, Bren, is that our inspections are unannounced in adult social care, and so it's actually very difficult, therefore, to set up in advance listening events. We are, however, doing a couple of things at the moment. We are piloting a way of sharing information with people who are using services and relatives and families and carers, that the inspectors are either there on the day or have been there to provide details for people to contact us either on the day of the visit or subsequently, so that we can hear from them. And secondly, we do, and particularly in domiciliary care services, where it's obviously very difficult for us to observe care, we are issuing questionnaires to people who are using services to get their feedback, and our experts by experience will also talk to people during the inspection, but subsequently on the telephone as well. So we're trying to capture that information in different ways, bearing in mind the fact that we obviously don't give people the notice that Mike does for the hospitals.
Steve?
I would echo what Andrea said, but I think looking forward, clearly what we wanted to look at is what care is like across a geographical area. And so we want to piggyback on the back of some of Mike's open events for hospitals, because you can then ask questions about what is care like for the elderly in Droitwich or whichever town you're in, and I think you'll get a better picture then. I found out a lot about GP surgery's provision for children, including about my own surgery, by visiting the children's reference group at Birmingham Children's Hospital when we were doing the Future Forum work, because the children drift towards, because of clinical care, to Children's Hospital, but they're not shy at talking about the surgeries. Whereas if you ask them to attend a surgery for a meeting over the number of surgeries they've got, logistically it's very difficult. Ditto elderly people working with homes and things.
Well, thank you all very much. Questions from the public are very important for us. As I say, unfortunately, we can't go on today because of this room being used for this other purpose. But thank you very much for coming, and we look forward to seeing you at our next board meeting. And I can now draw the meeting to a close. For colleagues who are staying on, we're moving to room 1A, which I think is effectively just across the corridor. So.